session. May I have your attention, the esteemed faculties and delegates? I would like to take a few moments of your time to introduce myself and the distinguished faculty members of this session. A very good afternoon and a warm welcome to all the dignitaries present over here today. I am Rituparna from Clarinet, serving as the allocated session assistant to ensure a seamless experience. Clarinet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. And it is with great pride that Clarinet serves as the digital partner for this online event called Neonatal Pathshala Series, hosted by the National Neonatology Forum Gujarat chapter. The focus of today's session is POCUS Series 21st episode live demo of normal views in cranial ultrasound. Now, without wasting any further minute, let's begin today's session, for which I would like to invite none other than Dr. Kunal Ahiya sir, the Honorable Secretary of NNF Gujarat, to start the event today with his enlightening words and for the further coordination. So the dice is all yours, sir. Please proceed.
Thank you so much, Ritu. So it is our great pleasure that we are continuing with our Neonatal Pathshala series, and in which we have a special series of POCUS. So today is our 21st session on POCUS. So initially we had covered the echocardiography part, and now we are covering the neonatal cranial ultrasound. So previously we have heard two of the topics regarding the cranial ultrasound, the anatomy and the normal views. And now we will see the live demo, actually how do we perform this. So for which we have none other than Dr. Mohit Sahni sir, who is an expert in this field. And we are having a pleasure to invite you, sir. Thank you so much for continuing with the series. For other formalities, I will request Dr. Vishal Goel to take over.
Thank you, Kunal, and good afternoon, everyone. So today, session is regarding live demo regarding cranial uh, ultrasound, and for that we do have our own Dr. Mohit Sahni sir. He is not only the national but he is the international faculty. If I talk about the neo-hemodynamics, and he does not need any introduction because he is like one of the pioneer of the neonatal hemodynamics. If I talk about the India. Currently, he is the director of Neonatal Focus Eco Academic Surat in India and director and senior consultant at Surat Kid Hospital, Surat. He was editor in the Chief Journal of Neonatology India 2017 to 2022. He was president NNF Gujarat from 2020 to 2021, governing body member for NNF Western Zone 2017 and 18, and member of Neonatal COVID Task Force Government of India. He is the editor of a major book, if I talk about the neonatology, hemodynamics, point of care ultrasound, and the echo, and neonatal focus echo made easy. It is always pleasure to listen the sir all that anytime. If I talk about the any session, not only the neonatal hemodynamics, but even any topic of the neonatology, he is a wonderful person to listen him. So I welcome sir, and over to you, sir, Mohit sir.
Thank you, Dr. Vishal. Thank you, Dr. Kunal. So it's always good to interact with all of you in this series, what we have been continuing. And thankful to Gujarat NNF for making this happen. And this is happening for last more than a year or so. So as Dr. Kunal told, we have already completed the cardiac series. So we are now on head ultrasound. So you have already gone through the lectures on the views of the head ultrasound. So today we will do the live demonstration of the same views what has already been discussed in the previous sessions. So as you must have gone through the previous lectures, so we have like views, we can do it from the fontanelles. And the most common fontanelle which six, and then in sagittal we have 5 sections: mid-sagittal, parasagittal, and periventricular. Then I will also show you the windows from the other fontanelle, that is from the temporal fontanelle. Those are the special windows Particularly, we will only discuss what all we have to see through them. And then the mastoid fontanelle through which we have the mastoid window. So we will start with the anterior fontanelle with coronal section. So this is phase array probe. The best probe to do the head ultrasound would be the curvilinear probe, in which the foot is like a curvilinear. But this in the initial basic classes or the basic principles, and when we discussed regarding the probes, we have already talked about that there is some difference, there is some benefit in curvilinear probe by doing the head ultrasound by curvilinear probe is bit better than the phase array probe, but that adds to the extra cost. So in my unit, I don't have the neonatal curvilinear probe. So we do all the abdominal ultrasounds, head ultrasound with the phase array probe. Phase array probe is the probe particularly for the cardiac views. ठीक है ना? For the cardiac views. When we press this preset, so all options they come. So here we have head ultrasound term, head ultrasound preterm. So this is a baby, which is a preterm baby. So therefore I will select head ultrasound preterm. As soon as you take it, this probe orientation marker will come on the right side of the screen. For cardiac, it is on the left, but here it is on the left side of the screen. Okay, so and we will see where this probe marker, this will face on the baby's head when we put it on the anterior fontanelle. ओए इधर से लाइट आ रही है, ये वाली ग्रीन शेड यहाँ रख दें. कौन सा उधर से? हाँ उधर से बंद कर दो. We put the gel. I'm just warming the gel under the. So this various settings on the machine have already been preset as per the head ultrasound settings. इधर से पकड़ बेटा. So now here, this is the AF, anterior fontanelle, here. So when we put the probe in the AF, we will keep this probe marker on 9 o'clock. That is on the right side of the baby. If this is the clock, here will be the 12 o'clock, 6 o'clock, 3 o'clock on the left, and 9 o'clock on the right. So I'm putting the probe on the baby's AF, anterior fontanelle, with pointer pointing at 9 o'clock. That is toward the right side. And we always start from the most interior section. Like from interior, we sweep posteriorly. So C1 will be most interior. Slightly go backwards. Posterior is C2, C3, C4, C5, and C6 is the most posterior, like this. Yes. So we go from most interior to posterior. So we will see various sections: C1, C2, C3, C4, C5, C6. So we start with the most interior section. The main thing is you have to keep this in center. This everything has to be centralized. So here you see this is the orbital ridge. Orbital ridge, frontal lobe, frontal hemisphere, orbital ridge, and this is interhemispheric fissure. Interhemispheric fissure, orbital ridge, and this is the frontal hemisphere. Then I slightly go back, sweeping posteriorly. So this is C2, interhemispheric fissure, corpus callosum, cavum septum pellucidum, and then anterior horn of the lateral ventricles. So this is C2. Then we go to the more posterior section, and that is the most important section of all the coronal sections. That is what we call as C3, coronal section 3. So this is something very important because in this section, we look for ventricular index, anterior horn diameter in hydrocephalus, and any bleed is there. So all those things we will cover in the later on, we will cover in these sections in Pathshala. So in this, you will see interhemispheric fissure. This is corpus callosum, red roll sign like you see, cavum septum pellucidum. This is anterior horn of the lateral ventricle, Sylvian fissure here. This one you are seeing. And then here comes the third ventricle, which is not visible in this baby. In many babies, it is visible. In some babies, it is not in this coronal section. And then here we have the caudate nucleus, thalamus, caudate nucleus, thalamus, globus pallidus, putamen. Globus pallidus, putamen, caudate nucleus, thalamus, Sylvian fissure, interhemispheric fissure, corpus callosum, cavum septum pellucidum, anterior horn of the lateral ventricles. So this is C3. And then we move a bit more posterior. When we go more posterior, this is what we call a C4 or 3-dot sign. So why we call it 3-dot sign? There we see 3 hyperechoic shadows. Here, these are the choroid plexus, and this is the roof of the third ventricle. Here you can see there is one cystic lesion is there. So in this baby, you have the choroid plexus 6 on the right side. Here you can see this is a probe marker, orientation marker, and my probe marker is pointing at 9 o'clock. That is towards the right side. So that's why. So I have a choroid plexus cyst on the right side. So this is 3-dot view, or what we call as the C4 section. And then if we go more posterior, you start seeing this choroid plexus. Sometimes it is symmetrical. Sometimes you see one choroid plexus better in one view and then another one in another view. So these are the choroid plexus or trigon view. Main thing is you have to keep it centralized. So these are the choroid plexus. This is the posterior horn of the lateral ventricles. So this is the choroid plexus. This is the posterior horn of the lateral ventricles. So this is trigon view. And then when you go more posterior, so you will see this occipital lobe. And now from C4, see this is C3. And this is C4, 3-dot view. You start seeing the cerebellum. In C4, you start seeing the cerebellum also. Till C3, cerebellum is not very clear. From C4, that is 3-dot view, you start seeing the cerebellum. And then in trigon view, where the choroid plexus is seen, very nicely you can see this cerebellum here. And then similarly, you will have this view of the cerebellum. So you have cerebellum clearly seen in coronal sections C4, 5, and 6. This is again intrahemispheric fissure, and these are the occipital lobes. So these are the six coronal section from C1 to C6 when we move from anterior to posterior. I do have Dr. Kunal with me. He is one of our students for NEFCO, and he is there for the physical training. So he is also been getting trained in this session. So I hope this is clear. If you have any questions in coronal sections, you can please put down in the chat box. You want me to repeat anything or you want to see it clearly? Anyone, if you have any doubts, you can please put in the chat box. Here, all the structures. So if it is not there, then we will go for sagittal sections. Structures. The structures, I hope I have mentioned everything. Okay. And now I will go to the sagittal views. इसका शक्ल सेंटर में पकड़ बेटा सर so sagittal view in coronal sections the pointer was pointing at right side, that is 9 o'clock. Now we will rotate the pointer, and now the pointer is pointing at 6 o'clock. It is in the AF, but the pointer is pointing at 6 o'clock. So this is left side sweep and right side sweep. When we will start, we'll start the mid sagittal in the middle, and then we can go for left parasagittal, right parasagittal, and this is right periventricular. You have to sweep more on the right side, and then for left periventricular, you have to sweep more on the left side like this. So this is sagittal views. So this is known as lady in dress view or mid sagittal view. So in this, this is corpus callosum, cavum septum pellucidum. This is foramen of Monro. Here, foramen of Monro. Here you have the third ventricle, fourth ventricle, cerebellum, midbrain. So lady in dress view, it like you must have seen in the previous presentation, it looks like lady in a dress. Corpus callosum, cavum septum pellucidum, foramen of Monro, third ventricle, fourth ventricle, cerebellum, and then midbrain. Very nicely now you can see foramen of Monro, third ventricle, fourth ventricle, all connectivity you can see. Cavum septum pellucidum, foramen of Monro, third ventricle, fourth ventricle, cerebellum, and midbrain. So from here, when we move either left or right, that is, this is parasagittal, left parasagittal. So what are the structures in left parasagittal? This is the anterior horn of the lateral ventricle. This is the occipital horn, and this is the inferior horn. Anterior horn, occipital horn, and inferior horn of the lateral ventricle. This is choroid plexus. Here is caudate nucleus. Here is thalamus. Caudate nucleus, thalamus, and this one here. This is caudothalamic groove. So in caudothalamic groove, that is a place where first you will look at germinal matrix bleed, or what we call as the grade 1 bleed. So this is your caudothalamic groove. This is choroid plexus. Anterior horn, occipital horn, inferior horn of the lateral ventricle, that is periventricular. Here you see this is your parietal lobe, occipital lobe, temporal lobe, and this is your sylvian fissure. Parietal, occipital, temporal, and this is the sylvian fissure. So this C6 is particularly we see the PVL, periventricular leukomalacia changes in this particular view. So these are your six sections, C6. Sagittal, and this is your sagittal views. First, what we did was mid sagittal, in which we see lady in dress view. So there you had corpus callosum, cavum, septum pellucidum, foramen of Monro. Thank you. And then we had third ventricle, fourth ventricle very nicely was seen in this baby, and all communication you could see from foramen, cavum, septum pellucidum, foramen of Monro, third ventricle till fourth ventricle. The whole communication was being seen. And then we had cerebellum and the midbrain. So then we had parasagittal, in which you saw choroid plexus, inferior horn of the lateral ventricle, occipital horn, and the inferior horn. We look at an area where you have the caudate nucleus, thalamus, caudothalamic groove. Okay, so that is a position where that is a place where we look for the grade 1 IVH, or what we call as the this thing. So that is the area where it is first grade 1 IVH can be detected. It can be seen in the coronal and sagittal. And the practical point is, whatever you see in coronal section, you should able to see it in sagittal. So you should be able to see same pathology in both the sections to confirm that pathology. Grade 1, grade 2, that you should confirm grade 1, grade 2 in coronal as well as sagittal view. And then when you sweep it more lateral, that is periventricular, which I just show you, in which we saw parietal lobe, occipital lobe, temporal lobe, and the sylvian fissure. And that particular view is basically for the PVL, periventricular leukomalacia. So that is important. So now we will go to, from the anterior fontanelle, we go to the temporal fontanelle. This is for the special views. इधर इसको थोड़ा टेढ़ा कर दे बेटा इस तरफ, right side. So this is the positioning of the temporal. This is the end canthus of the eye, and this is tragus of the ear. So the line joining the canthus of the eye and the tragus. In this line, you will have the temporal fontanelle here in midway. So where you put the probe at this place where the probe pointer pointing at around 45 degrees, making 45 degrees to this line. This line, it makes 45 degrees to this line here. So we put it like this. Here. Yeah. Wait. No. So this view, basically in this view, we look for third ventricle, do the diameter of third ventricle, fourth ventricle, and we look for circle of Willis in this. This is the easier and good view to look for the third ventricle diameter. So this is your third ventricle. So this is your third ventricle here. So you can take the diameter of the third ventricle. It is 1.6 millimeter. So this is useful in hydrocephalus. If your third ventricle diameter is more than 3 millimeters, that shows you should take the action. There is a significant hydrocephalus. So this helps in that. So when we will do hydrocephalus, we will cover all these indices. So this is the view where we look for third ventricle diameter in third ventricle, and then you put a color. Here you can see this is a circle of Willis, complete circle of Willis. Complete circle of Willis. It is very rare to get the complete, but significantly I am getting the things. This is middle cerebral artery, anterior cerebral artery, and this is posterior cerebral artery. So all the three ones I am seeing. So we can do the Dopplers of the middle cerebral artery here. This one. You can see I am putting the pulse wave Doppler here. And this is the tracing for the middle cerebral artery. So this is MCA Doppler. So here we can do the Dopplers of MCA and the middle cerebral artery and even posterior cerebral artery also we can do, because circle of Willis you will see here. And the structures, main structures, what you see in this was third ventricle. And now we will go for the mastoid fontanelle. I will just show you where you will have the mastoid fontanelle and how to keep the probe. So mastoid fontanelle is just behind the ear here. So when we put the probe, we put the probe in two ways. One is like this, where the pointer is pointing at 12 o'clock. And the other one is where the pointer is pointing at where the pointer is pointing at 9 o'clock, 3 o'clock here. Okay, the views will be almost, so most commonly we do by putting the probe on the mastoid just behind the ear, and the pointer is pointing at 12 o'clock. The major things what we see in this view is fourth ventricle is clearly seen in this, and then we have cerebellar hemisphere, vermis. So these are the few things that we will be looking in this view. So here you can see these are the cerebellar hemisphere. This is cerebellum. The whole, this is one is right and the left. So this is cerebellum. The constituency of this, the hyperechogenicity, you will look, it's different from the rest of the brain. This is a lateral ventricle, right and left. These are the cerebellar hemisphere, and here you will have a vermis. So here, what we can do is we can take the diameter of the body of the cerebellum. So I'm taking the diameter of the body of the this thing. It is around 29 weeks and 3 days is what I've got to the diameter. And this baby is 30 weeks gestation. Okay, so that this is there is a strong correlation in the cerebellar diameter, and there are many published papers on this. The cerebellar diameter is equal to the gestation of the baby. So this is one thing you can do, and then we look for any cerebellar hemorrhage is there. If there is a hemorrhage, it will be hyperechoic. If there is hypoxic insult to cerebellum, so then again it will be hyperechoic. If there is anatomical issues in the posterior fossa, like you have a Dandy Walker or something, then this vermis and then this cisterna magna will be dilated. So dilated bigger cisterna magna. So that will be there. So those things we can look in these views. And the other one is the fourth ventricle. I will just show you the fourth ventricle, and that is also if your diameter of fourth ventricle is more than 4 millimeters, then again that's an indication for an intervention in hydrocephalus. Every baby is different. In temporal view, I'm able to see the fourth ventricle better as compared to the mastoid. So there, here, I'm temporal view, I'm able to see the fourth ventricle. This is the fourth ventricle. So the diameter is around 2.7 millimeters. So I'm seeing this in temporal view. The fourth ventricle is better seen as compared to the mastoid. So if there may be overlap, but most commonly in temporal third ventricle is seen better. Fourth also people they do you can do from there. In mastoid also you see the fourth ventricle, and then basically it is concentrated on the cerebellar hemisphere. So that completes the commonly done views in the head ultrasound of the newborn. Coronal, 6 sections, sagittal, 5 sections, and then temporal fontanelle, and then mastoid fontanelle. Now, if anybody has got any questions, you can please ask.
इन्फॉर्म कर रही थी मैं पेंट्री में ही हूँ इसका फीडिंग का हो तो बुला लेना मैं इधर ही हूँ
Dr. Kunal,
Yes, sir.
so this live demo is completed. If anybody has got any questions, I can.
Sir, RI, that will cover in
Parasagittal views. Okay. I will repeat parasagittal. क्या आ रहा है क्या? Sorry.
sir, RI or उसके that will take now or later on, sir. RI, PI.
No, that is a Doppler. We will do it in the Dopplers.
Okay, sir.
So, so that ventricular index we will do in when we will discuss hydrocephalus. So we will have sections on pathologies. So there we will cover the ventricular index. Okay, I will just repeat the parasagittal again. के सेंटर पकड़ ले बेटा मुंह में निप्पल डाल दे इसके अंदर So this is mid-striatal. This is lady in dress view. Corpus callosum, cavum septum pellucidum. Foramen Munro, third ventricle, fourth ventricle, choroid plexus, and mid. Anterior horn of lateral ventricle, occipital horn, inferior horn, choroid plexus, caudate nucleus, thalamus, and very nicely you can see this caudothalamic groove. Caudothalamic groove. And then we go more lateral. So this is parietal lobe, occipital lobe, inferior. This is temporal lobe, and this is Sylvian fissure. I hope it is clear now.
Uh, if anybody has any questions, they can unmute themselves and ask also. I think there are no questions.
Hello.
Yes, Dr. Kamal.
In preterm baby and full term baby, what are the major differences in parasagittal and coronal view?
Not much. The structures remain the same. Only thing is the density of the tissue will differ. And if the babies are very preterm, then your sulci and garai, that differentiation, what you look, will not be the same. Like in 24, 25, 23 weeks, it will be a kind of flat brain. So we won't have any sulci and garai much. But rest of the structure.
Right. Thank you.
Any other questions? Yes, Dr. Vishal.
Hello.
Dr. Vishal. Yeah.
Yeah, I think there's no any question. I think that there's nothing from the audience. I think very well explained by sir. All the normal view.
Sir, there are no questions. If you permit, we can conclude now. Okay, sir. So thank you all. Thank you so much, Mohit sir, for the wonderful session. You had explained it, studying a theoretical part and learning from the practical aspect are two very big different things. And you made it so easy. Thank you so much. I think somebody has just now posted a question. How frequently you should do in preterm? Sorry, sir.
So, yeah, that's fine. It was, it must have been discussed, I think so, in the previous sessions.
Yes.
So what we do is first we try to do it at 24 hours, or if the baby is very preterm and sick, then we can do it in first 24 hours also. So 24 hours, like in between 2 and 3rd day of life, then 5 to 7 days of life, 14 days of life, 28 days of life, and then corrected term. So this is the normal sequence for a preterm head ultrasound. And anytime when you detect IVH, PT-INR has been deranged, baby is hemodynamically unstable, then you can do as per the requirement. And suddenly, if there is um, fall in the HB, if there is a ELBW baby, sudden fall in the HB, then you should not wait for the days and as your protocol, you should do it immediately to see whether the head ultrasound, whether the IVH is there or not. And the corrected, we do basic 28 days, and corrected one is basically for PVL. So that PVL ultrasounds are, we will pick the earliest PVL. Normally we pick by 2nd week of life, but we have one 600 grammer. There, we could see the PVL on 7th or 8th day of life. The initial started. So that is basically your hyperecho because you have a non-cystic PVL and cystic PVL. So those things we will discuss when at the appropriate pathologies. So, but the normal timeline for the head ultrasounds in the ELBW especially is second day, 2nd to 3rd day, 7th day, 14 days, 28 days, in corrected term.
Okay, sir. Thank you so much, sir. Vishal, you have anything to say?
No. Thank you so much, sir. I think it is well explained. And okay, another question is how to differentiate. But I think sir will explain in the next session, maybe and when we cover the hydrocephalus and the PVL. This is for the normal view only. So, am I right, sir? Just
Yes.
yeah. uh, So thank you so much, sir, and it is always pleasure to listen, sir. And I hope we continue for many more session every monthly. I think on the second week we are continuing the focus series, and I think we can conclude the thing, Dr. Kunal. Thank you so much, sir.
Yeah. Thank you,
Thank
Mohit
you.
sir. Vishal. Thank
Thank
you,
you.
ClearNet, for the
Bye.
seamless
Thank you, sir.
experience.
Bye, sir.
Bye. Bye, everyone. Ritu, we
Thank,
can conclude now. Yeah.
thank you so much, everyone, for sharing your valuable insights. I hope you had a seamless experience. So, with all your permission now, if there are no further queries, we would like to sign off for today. And looking forward to host you again very soon in another interactive session. And before we sign off, wishing you a happy Holi in advance.